already know the heart is a pyramidal shaped structure. The pericardium, and with a good amount of epicardial fat where the coronaries are wrapped around and course predominantly epicardial with some variations. And as it is, there is off-axis rotation of the heart, so it is not in the proper body plane, and we require imaging in planes as you see on echo. So on CT, this is very easy to make, and we can the same morphology, same picture on the short axis images and 2 or 4 chamber images we can see. We can see the coronary course as mirrored to echocardiographic practice and as well as on the volume rendered images. Moreover, we should see for the osteal pathology or some branch abnormalities, because these vessels are very small and they should not be missed. So it demands a very high quality acquisition of the CT. We have to see all the existing phases which we get on CT, because there may be heart rate variability. We can see there is degradation of the images, and in some phases, if we have acquired in adaptive phases, we can see images on some good quality phase, and that should be interpreted well. And the portion which is in the artifactual range should be clearly mentioned, so as we should not miss any lesion along that plane. So we use various images as far as highlighted. First, it is the most important image for the radiologist is the axial image, and this is the normal CT acquisition image. We see pathology on this and then highlight it on the other images which shows the image, abnormality quite glaring. So for anatomy delineation, we can use these projections very nicely, as well as curved reformation, which can show the whole length of the coronary involvement along in one plane in one image for all the coronaries. So this, to highlight the anatomy, I will be using the adult coronary images to show exact the anatomy as well as their origin and course, which we see on the pediatric population. And these small branches may not be seen very well in case of kids, but the larger arteries are very nicely seen. So they arise from their respective aortic sinuses. The right coronary from the right sinus, which is anteriorly placed, and left coronary from the left sinus, which is posterior. And they course epicardially. We can see this aorta and the coronary, which is both the two coronaries, they are arising. This is the RCA and this is the left coronary, which is bifurcating into LAD and LCX. In one image, we can see full coronary tree on CT, some form of reformation. So coming on to the left coronary, how it arises, the origin I have discussed. It is from the left sinus, and then after a variable length, which may be 5 to 10 millimeter, it then bifurcates into left anterior descending coronary and left circumflex artery. There may be variations in the bifurcation pattern. It may be trifurcation in up to 15 to 30% of the cases, which then may give rise to the corresponding branch, which can be ramus intermedius, which can supply to either the diagonal or the obtuse marginal territory. So then LAD courses epicardially with some portion of bridging in some cases, and it give rise to the diagonal branches and the septal branches. So generally the diagonal branches, they arise laterally and supply the anterior left ventricle, and the septal branches are medially to supply the septum. Septum branches are septal blush, they are very small branches, And generally we see for the bigger, main the LAD and the diagonal branches for any abnormality in Kawasaki disease. So then left circumflex, it courses in the left atrioventricular groove. This is the left atrium, this is the left ventricle. So the characteristic course along the groove gives rise to the name of left circumflex. This is the left circumflex. It is clearly seen, and then continuing as smaller last OM branch. And this is the biggest OM branch in this case. We can see this is the smaller O1. These branches, they arise and they are numbered sequentially, like OM1 is smaller, OM2 is larger, and sometimes if there is larger OM, then the distal circumflex is smaller. It may give rise to the posterior descending artery or the posterolateral branches if there is left dominant circulation. Then the right coronary, again the origin I have already told, from the anteriorly, and then it branches. The branches are, the first branch is the conal branch, which is towards the conus. So it will follow the anterior course and supply the RVOT. In some cases, it has a direct origin from the aorta. Then it is sometimes referred to as third coronary artery. But majority of 50% of the cases, it is from the 50 to 60, it is from the RCA only. But we have to see if there is any abnormality when it is directly arising from the aorta. So then it is acinodal branch. It is just for the anatomy delineation. This branch may not be seen. And these branches are so small in pediatric population, they may not be very well visualized on CT. And this course is identified that it is the coronal branch is going anteriorly and it is going posteriorly to the SVC inflow region. Then the easily identifiable branches are the acute marginal branches, which are on the acute margin of the heart, and they are known as acute marginal branches before distal RCA bifurcation into posterior descending and posterior circumflex arteries. So we can see at the crux of the heart, it then bifurcates. So this is going to the posterior interventricular septal region, like this one. It is the PDA, and which is to the posterior and inferior left ventricular lateral wall, posterior wall, it is the posterolateral ventricular branch in case of right dominant system. And the coronary, only coronary artery tree, we can see whole length of the RCA and LAD in one plane. So to better delineate, we can see the whole course of this is the origin of the RCA, right atrium, right ventricle, right AV groove. So we have to see in the groove, if on the right side it is RCA, on the left side it is left circumflex, and anterior ventricular sulcus, it is the LAD. So we have to identify it like that. We have to see for the atria and the ventricle and the corresponding grooves. So two arteries which are in the grooves is right, on the right side, right groove, it is RCA, left groove, it is LCX, and which is not in the groove in the center, it is LAD. So the dominance is, majority of the cases it is right dominance with small subset in the left dominance. So the importance is, if there is small length RCA, it is generally very small if there is left dominant circulation, and then the larger branches, the PDA is supplied by the left circumflex. So the nomenclature of the coronaries is also based on this principle, that which territory it supplies and which branches it gives. So particularly in kids, we can see the anomalous origin of the coronaries. So if there is anomalous origin, like in this case, this is left coronary and this is the right coronary from the same sinus, and this is the high origin of the right coronary. So this anomalous origin or anomalous proximal course still doesn't change the name of the coronary. If it courses in the right groove and supply the right side structure with the acute marginal branches, it is still the right coronary artery. And similarly, if we have anomalous left coronary, sometime we have anomalous left circumflex from the RCA or right coronary sinus, but it will course again in the same groove. If it is not in the groove, then it is atresia of that particular artery. So the nomenclature is, it does not depend upon its origin or proximal course. It can be anomalous, but for normal, it has to be its ply. So when on CT, whenever we review the images, we have to give particular attention for the branching points of the larger branching points, and to see for associated abnormality. Like with the aneurysm, you need to see for any stenosis as well, and you have to set or change the kernel reconstruction to avoid overestimation due to high density adjacent structures. So all lesion characteristics should be noted, like the length, eccentricity, ostial involvement, any ulceration, irregularity, calcification, vessel wall remodeling in the chronic phase, occlusion or aneurysm formation, and its dimensions and its extent, whether it is involving the branching point or whether it is involving one coronary, proximal coronary or distal coronary involvement. So coming on to the abnormalities or pathologies which we encounter in Kawasaki disease, it can be the most common in following acute phase or in subacute phase. It is the aneurysm formation, and the aneurysmal dilatation, it could be fusiform, as we can see fusiform, where the length of the involvement or the length of the aneurysm is more than its transverse diameter. However, it can be both combined. It can be fusiform as well as secular, also secular when it is the transverse diameter which is more than the fusiform, than the length of the abnormality. So as this has been shown by sir previously also, there may be one coronary involvement like RCA in previous case, or there may be both the coronary involvement like RCA and LED in these cases, and it is the fusiform dilatation involving the proximal, mid and the distal segment. And the measurement of this, like the giant aneurysm more than 8 millimeter, particularly in children. So, or it may be the involvement of the distal, proximal as well as distal arteries, and the remodeling following this resolution of the acute subacute phase to see for the aneurysm resolution or its changes in the wall thickening, calcification and occlusion. So CT is particularly highlighted being important for delineation of the LCX abnormalities, which may not be properly picked on echo. And we can see whole length of involvement as well as its morphology and its location, eccentricity and all features. So then subsequently we may see the changes on the wall as well as formation of calcification. We can quantify the calcium score and with it or its progression, or if it is same during the follow-up. So these aneurysm may show peripheral thrombus. There may be thromboembolic complications, or it may calcify peripherally with central occlusion. Then we have to see for the effects of this thrombus. So we have to also pay attention to the short axis images, which I already have told earlier, to see for the effects. If there is chronic ischemia, there will be wall thinning along the particular territory. If this is the aneurysm in the thrombosed aneurysm in RCA, and this is the thinning along the inferolateral inferior wall in the mid cavity region. So to conclude, there is, with the advent of this technology, there is considerable change in coronary and cardiac imaging, and these advancements have enabled detailed evaluation of the anatomy and pathology of coronaries, and the knowledge of anatomy is important for accurate interpretation of these imaging findings and to avoid missing any abnormality. Thank you.
Thank you for taking for detailed evaluation of the coronary artery comments or any questions? Yes.
How will we differentiate the scapular aneurysms from pseudoaneurysms and aneurysms in the cities?
No, on this basis of CT, it is not possible distinctly because it is a pathological condition. Pathology which that there is all the walls are there or not, but there is some hint that there is surrounding hematoma. Only then it will be differentiated from aneurysm to pseudoaneurysm. Otherwise, they are just named interchangeably. Not 100%. It is not clear cut for aneurysm and pseudoaneurysm distinction on CT.
Usually pseudoaneurysms has a smaller neck. Usually these are the small features, but in Kawasaki these pseudoaneurysms are not being reported. So, on that context, I will tell you in 3 words, coronary artery anatomy. We think of talk of origin, we talk of course, and we talk of termination as Dr. Arun has highlighted. It may origin from anywhere, but usually they have a predictable course. If RCA is rising from the left sinus, it has to go to the right side. It's an anomalous origin, maybe an anomalous course, but ultimately going to the right direction. So this is the predictability, and most of the coronary arteries are epicardial. It doesn't go into the myocardium until unless they supply that area. So these things are important. And as Arun has highlighted, right side on the AV groove is right side, on the left is LCA, which goes anteriorly, and in the center is LMCA. So I think then morphology of the aneurysm secular versus fusiform, as you follow them and you can stenotropic lesions, you can have calcifications. I think if there are none question, thank you, Dr. Arun.
Thank you,
for
sir.
your wonderful presentation, and thanks for coming.
Thank you.